Hi, good afternoon, everyone, and welcome to the webinar today on the 12th of October. I'm very happy to see all of you here today, and we are going to be listening to Professor Dr. Phyllis Lau for a lecture today. So let me just give you a brief introduction about her. My name is Pauline, and I'm from the Department of Primary Care, and we're very happy to have Phyllis with us today. Phyllis is affiliated to two universities, the Western Sydney University and the University of Melbourne, Australia. She obtained her Bachelor of Pharmacy degree and PhD from Monash University in Australia. She was recognized for her work in interprofessional collaboration with oral health practitioners when she was invited to be a founding member of the National Integrated Oral Health Alliance that promotes integrated oral health care and the Pharmacy Oral Health Alliance that advocates on a politically challenging platform for accessible oral health care through non-dental health professionals. So without much ado, I would like to invite Phyllis to begin her lecture.
Thank you. Thank you to Pauline for your kind invitation to conduct a webinar with you. I will share my screen. So thank you, Pauline, for inviting me again. And I enjoy doing this online sessions with you, but really hope to be able to travel to Malaysia soon and to meet some of you in person, perhaps. In Australia, we have a tradition of acknowledging the country, of the traditional country of the Indigenous people when we're doing a presentation. So please allow me to do that. I want to acknowledge that I am on the land of the Wurundjeri people of Melbourne, and to pay my respect to elders past, present, and future. So this is what we always do with any presentations that we do from Australia. So today I will talk about halitosis. Well, it's not really about halitosis, but mainly the focus will be on the Say Ahhh project, which was a collaboration between the dental school at University of Melbourne and two practice-based research networks. I don't know how familiar you are with the concept of practice-based research networks, and I hope to be able to later on in the year to give a bit of a webinar on that too, because it is tremendously important to research, particularly in primary care research, practice-based research networks. So for the benefit of those here, there's not a big crowd, but I'm going to assume that not everyone are clinicians. I will go through very quickly what is halitosis and what are the common treatments to start us off. But I'm not a dentist. Some of you may already know. I am aware that there are many more learned dental colleagues who can do a far better job than me in explaining to you what is halitosis and what do you do about it. So please, if any one of you feel free at all that you could fill a gap in what I will be saying, please feel free to interject. But as I say, my presentation will really be more of about the halitosis part will be more of a prelude to what I will want to talk about the Say Ahhh project. Sorry, could you see the grid that I was with the pictures? Okay, so this afternoon we will look at what is halitosis, who gets it, what are some of the common causes and management, and of course we will then talk about the Say Ahhh project. So definition of halitosis. Halitosis is basically a noticeable and chronic unpleasant breath odor, or more commonly known as bad breath. So who gets it? We all do. Up to 50% of the population has bad breath at any one time. We all remember that one kid in school who had bad breath, or maybe it is us who is that kid. And we all can remember a time when we talked with someone with bad breath. Or again, maybe it was us that didn't even know that we have bad breath. And let's face it, who dare to say that they have not noticed their own breath with the face mask that we all have to be constantly wearing these days. Now, this seemingly minor condition is associated with a lot of social anxiety low self-esteem, insecurity, and even isolation. And halitosis, particularly when it's chronic and irretractable, can have really negative impact on quality of life. Bad breath is the biggest turn-off when it comes to finding potential partners, according to research done by the Oral Health Foundation in the UK in 2019. A survey into attraction reveals that bad breath will be a big turn-off for 85% of British adults looking for a partner. And single Brits have deemed halitosis a bigger faux pas than bad jokes, terrible dress sense, lateness, and even poor manners. But really, the biggest reason why we should be concerned about bad breath is it may be a sign of serious underlying disease. Halitosis can be caused by many factors. Our exhaled breath is a mixture of hundreds of volatile compounds. So our volatile sulfuric compounds are mainly produced in the oral cavity and under normal physiological conditions. In oral diseases such as bleeding, reduced saliva, bacterial infection, gingivitis, or periodontitis, these sulfuric compounds then accumulate and lead to what we call intra-oral halitosis. Then there are also the non-sulfuric volatile organic compounds which are produced due to distal pathophysiologies, including but not limited to respiratory, liver, kidney, or gastrointestinal disease, eventually leading to what we call extra oral halitosis. So most halitosis is temporary or self-limiting. It can be caused by food that we ate, such as onion or garlic, poor oral hygiene, dehydration, dry mouth, smoking, or sometimes the coffee and the alcohol that we drink. Some common intra-oral causes, like I said, periodontitis, and also caries, gingivitis, abscesses in the gums, low saliva, tonsil infection, oral thrush, oral cancer, and bacteria on the tongue. And common extra oral causes, and these are mainly more persistent and symptom of underlying diseases such as cold and flu, infections of the respiratory tract, lung infections, kidney, liver, ketoacidosis due to diabetes, starvation, or if you're taking a particularly high protein diet. Not all halitosis has a cause or can be managed physiologically. So pseudo-halitosis, where patients believe they have halitosis when there is no objective offensive odor. And halitophobia is a form of pseudo-halitosis, but that sort of belief that there's a smell when actually there isn't a smell has further developed into a fear. And this sort of uncommon cause is perceived. It doesn't exist. So it's more psychological and cannot be treated by dentists. They need specialized management and counseling, usually by psychologists. So how do we treat halitosis? For transient or temporary causes, maybe it was something you ate or drank. Avoid those food, coffee, alcohol, drink plenty of water, improve your oral hygiene, use pyxis, use a good soft not really soft, but toothbrush and a good toothpaste. Clean the back of your tongue. Mouthwashes can help, but usually in the short term. And I understand from my dental colleagues that any mouthwash that contains alcohol is probably not the best mouthwash to use. And if it doesn't go away, then dental assessment is needed. For halitosis with persistent causes, for example, oral diseases, so if it is oral hygiene and all that, you have to improve your oral hygiene and tongue cleaning. If it is your gum, something to do with the gum gingivitis or periodontitis, you may have to see a periodontist, dentist about it. And yes, you have to manage caries, any purple conditions and abscesses by going to see a dentist for all these wonderfully non-threatening treatments that is available. Of course, dry mouth is also a cause of halitosis, and you have to manage that. And a common way to do that is to use artificial saliva, not drinking lots of water as you would imagine. Although drinking water itself can help with a bad breath, but it wouldn't help with a dry mouth. Don't leave halitosis for too long, or you'll find that it will end up being a combination of causes that are causing the chronic bad breath. And finally, if after treatment halitosis still persists, then the patient should be referred for medical assessment. So finally, I've come to the collaborative project between the University of Melbourne and Epident Foundation, which is the dental PBRN, the Dental Practice-Based Research Network, and BigRAN, which is a primary care practice-based research network based at the University of Melbourne. The aim of Say Ahhh project is to improve halitosis management through collaborative care between GPs, dentists, and pharmacists. Because studies have shown that collaborative care improves halitosis management and increase detection of extra oral causes. In this particular study, we have included pharmacists. These studies also suggest that patients are equally, if not more likely to consult the more affordable and accessible health professionals, particularly for those in rural and remote areas. There are 3 phases to Say Ahhh. Phase 1, we investigated the practice and experience of dentists, GPs, and pharmacists in halitosis management, and we look at their attitudes towards interprofessional collaboration. In phase 2, we look at patients and clients' perspectives on halitosis management. And in phase 3, we then use the information collected in these 2 phases, the previous 2 phases, to inform a potential interprofessional care model to improve halitosis management. So in phase 1, where we look at what do dentists, GPs, and pharmacists do and know and do, we use a mixed methods design using online survey and semi-structured follow-up interviews. We recruited our participants widely because it was hard to recruit them. We recruited them from the Dental Association. We recruited them obviously from our 2 PBRNs, Epident and BigRAN. We also recruited through the Pharmacy Guild of Australia and through our own personal networks, including using a professional Facebook group that is close and some of us belong to. And we also got our dental students and our honor student to go to professional conferences and stood there with their iPads and asked dentists, doctors, and pharmacists who are attending conferences to participate in surveys. So the results of phase 1 has been published in the International Dental Journal. Just over 200 participants did our survey, 66 dentists, 27 GPs, and 114 pharmacists. And 5 from each of this group then were interviewed. About 2/3 of GPs and just under half of pharmacists thought that halitosis management is part of their role, but they all felt that the training that they have in oral health was insufficient. The majority of the dentists, GPs, and pharmacists thought that interprofessional halitosis would benefit their patients. Most participants, however, admitted to feeling really uneasy to start a conversation about halitosis, particularly when patients or the clients were not talking to them about their bad breath. They were asking their opinions about something else. So it was hard for them to raise the topic when even it was obvious. And most dentists, even if they did manage bad breath in their patients, did not monitor their patients' progress. GPs seems to be comfortable to manage halitosis only when it had a systemic cost, like related to diabetes or even when it's related to maybe a drug that they're using that is causing a lot of dry mouth, let's say. Pharmacists' role, and this was a slightly surprise to us to find that their role in the management of halitosis was not well understood by either the doctors, the GPs, or the dentists. GP and pharmacist participants were asked about their confidence when identifying signs and symptoms of different oral conditions. With halitosis and gingivitis, most GPs and pharmacists reported that they are very confident and or confident to know how to identify them. However, when it comes to periodontitis, the more severe form of gum infection, gum inflammation, only half of the GPs and only just 1 in 4 pharmacists will say that they are very confident or competent. In the survey, we also asked participants about their referring practices, whether they work with one another in treating halitosis. So about half of the GPs and about 1/3 of the pharmacists said that they either always or often refer their patients to dentists. And very few dentists or pharmacists said that they would refer to the GPs, and certainly none said that they would always refer. And similarly, very few GPs and dentists said that they would always often refer to pharmacists. Are you confused yet? Because if you are, I don't blame you. There's no need to be overly concerned with the numbers that are presented here. The take-home message is that all 3 professions seldom refer to or consult with each other when it comes to identifying and management of halitosis. But the important thing is most participants thought that better collaboration between them would benefit their patients and managing their halitosis. So like I said, we plucked 5 people out from each profession, so altogether 15 people, and we interviewed them and asked them to tell us more about their answers in the surveys. Now, this is a map that represented the themes and sub-themes elicited from those interviews. I won't be talking about all of them because it's just too many. Basically, there are 3 key themes from the interviews. The current practice, how health professionals perceive their own roles and collaborative care, and collaborative care. So I will highlight only 3 key sub-themes today to discuss, broaching the subject of halitosis and the barriers and facilitators for collaborative care. So first, how do health professionals broach the subject? How do they start a conversation of bad breath with the patients, especially when it isn't the main reason, the primary reason for their visit? Now, people think it is pretty offensive to bring up the topic. They thought that it is derogatory to push the subject if the patient didn't even ask about it. And what's more, they thought that it could compromise the doctor-patient relationship. Lack of knowledge and system issues were seen as barriers to GPs, dentists, and pharmacists working collaboratively. The fact that they are often not co-located is a barrier. And also there is no incentive. In other words, no reward, or to be more precise, no money in doctors to work with dentists. In Australia, the MBS, the Medical Benefit Scheme, funds team care arrangement and case conferencing, where GPs and pharmacists have opportunity to work together, but not with dentists. So dentists have really been left out of the loop. Dentists don't think that doctors and pharmacists know a lot about the mouth or are very interested in the mouth. And the impression is that GPs don't have a lot of time to spend with their patient. So more education for everyone is needed, especially GPs and pharmacists, on the more serious causes of halitosis. For dentists, this may be maybe even a little summary table or checklist to alert them to when halitosis is serious and need to be referred on for medical assessment. That could be helpful also. Health professionals thought that general public also need to be educated about when halitosis can be potentially serious. The doctor even suggested to create a halitosis Facebook page, but I suspect it will not likely to have too many friends or followers. So in phase 2 of Say Ahhh project, we explored what patients know and do. Firstly, we all should realize that most people, unlike us, even know the word halitosis or how to spell it. So very little is known about what the general public perception of what causes halitosis or bad breath, and the type of assistance that they would be seeking out. Anecdotally, we know that a lot of people, when they have bad breath, they're a bit conscious of it. They might avoid talking with their mouth open too wide. They might cover their mouth, turn around. Or more popular is chewing gum or using mouthwash. And like I said, there are certain mouthwash that probably does more harm than good, or they simply self-manage. Again, our phase 2 results have been published in the International Dental Journal. So in this phase, we have 6 dental students cold calling GP clinics, dental clinics, and pharmacies in Melbourne and rural Victoria. And they ask questions, they ask patients and clients who are at the clinic and walking around in the pharmacies, some short, semi-structured questions. So they ask them, have you had any experience of bad breath? So most people likely not wanting to admit themselves. So we said, either yourselves, your relatives, or your friends. What do they think about what causes bad breath? If you have bad breath, what do you do? And would you see a health professional? Why and why not? And is there anything else you would like to discuss about bad breath? Interview was just only a few minutes long each, and the interviewees got a coffee voucher for talking to our patients. For talking to our students. I was just thinking that it will just contribute to the bad breath if they have any at all. So a total of 122 patients or clients were interviewed in phase 2. When we asked them, have you had any experience of bad breath, either yourself, relatives, or friends? About 3/4 of them said yes. Either themselves, friends, or relatives have had bad breath before. That usually happened in the morning. When asked, what do you think causes bad breath? The usual sort of answers that we would expect from the general public were given as answers: the food they ate, smoking, poor oral hygiene, stomach issues, or throat infection. Some people with past experience of the more persistent halitosis have a better understanding of other slightly more serious causes of halitosis, causes such as tonsil infection, bacteria on the tongue, oral diseases, which are still within that oral region. But more serious ones are like cancer, diabetes, kidney or liver disease. So people do know what are some of the more serious causes. When asked if you had bad breath, what would you do? About 40% of them said that they would self-treat. They would manage with a trip to the pharmacist. They would get their inspiration from TV ads or look on the internet for solutions. And there are many rather weird and wonderful home remedies suggested on the internet. I'm sure if afterwards all of us Google a bit, you find some quite unique ones. Many would drink water, chew gum, brush and clean their teeth more often, use mouthwash and floss. Again, all this are what we expect them to say. Now, here is a little bit more interesting. Would you see when we ask them, would you see a health professional for bad breath? And why not? Very few would go to and see a health professional because they could treat themselves. It's not perceived as serious, it's normal. If patient did seek help from healthcare professional, most said, surprisingly, to us anyway in the team, is that they said they will see a dentist. 1/3 will see pharmacists, and only 1 in 10 said they will see a one third say that they will see GPs, and 1 in 10 said they will see a pharmacist. And even though most said that they would see a pharmacist, most of them thought that dentists are not as accessible as GPs or pharmacists. And the reason they gave are because GPs and pharmacists are cheaper, and pharmacists, you don't even have to make an appointment. You can just go into a pharmacy and see one. And pharmacists also sell different dental products which they can access. So what have we learned from phases 1 and 2? Halitosis is an issue, both within the healthcare professionals that should be identifying and managing it, and also in the general public. So we know that it can be a sign of an underlying disease, and it should not be written off lightly, especially if persistent. It could be better managed if healthcare professionals work together. And this is the same in any sort of disease area, not just in a condition like this. I personally am very interested in interprofessional care, and certainly the literature and all that all support interprofessional care. And more education is needed for health professionals and the general public. So in phase 3, we wanted to apply what we found to improve halitosis management. We developed 2 fact sheets in collaboration with Oral-B. And the first one is what is halitosis, which examines the causes of bad breath, and the management of halitosis, which provide advice on how to manage halitosis depending on the causes. Both fact sheets can be downloaded very easily and readily from the Evidence website, and they are designed to be widely disseminated to GPs and dental clinics and to pharmacies to improve halitosis management through collaborative care. Concurrent with the Say Ahhh project, the same team actually was also working on the DIABO study, and the DIABO study stands for Interprofessional Primary Diabetes and Oral Health Care. And the DIABO study looked at the relationship between diabetes and periodontitis and ways to improve collaborative care for patients. And because halitosis can be caused by periodontitis, we have combined the education rollout in the Say Ahhh project with the DIABO study. So for the 2 projects, we have developed an education program consisting of a pre-workshop module and then a 3-hour workshop where we have hands-on screening practice and also a case conferencing exercise. And we purposely pull different types of professionals together into that workshop, and then a 6-month post-workshop online refresher module. And like I said, we have different health professionals, GPs, oral health professionals, pharmacists, and because it was also related to our diabetes study, we have included diabetes educators. We have conducted 2 programs so far, and it demonstrated an increase in awareness, knowledge, and skills. And what's harder and more important to increase is a desire for more interprofessional involvement in diabetes and periodontitis care. So that is a really good outcome for us. What has been interesting for us, another interesting sort of event for outcome for us, is that we have not been able to recruit any dentists to the education program. We are currently seeking funding to test the interprofessional model. If you are interested in what that model looks like, I'm happy to show you afterwards, or you can email me later. So that's the end of my presentation. Other than Ivan Darby, and I forgot to acknowledge Ivan Darby in the start. I fully intended to. Ivan Darby is my co-investigator. So other than Ivan and myself, I'd like to acknowledge a whole heap of other people who were involved in both the Say Ahhh project and also the diabetes study. So I welcome any questions if there are any. So I might stop share if
Yes.
that helps at all.
Hi, thank you, Phyllis, for your lecture. It was actually really interesting. I found it really interesting. There are not that many of us in the chat in this group, and so far, even though I did ask everybody, the people here to actually type their questions in the chat box, no one has. So perhaps if anybody has any questions, they could raise their virtual hand, and you can either type it in the chat box, or you can actually feel free to unmute yourselves and ask Phyllis your question. Anyone?
I'm happy to answer any question, even if it is about the study design. So I don't know how interested people are in doing interprofessional research. So I'm happy to even discuss that, and not just purely about halitosis.
Maybe I'll start out with a question, Phyllis, since
Yes.
while waiting for the audience. In Australia, there are many community pharmacists, and every pharmacy would have a pharmacist. But this is actually a different scenario in Malaysia, because a lot of retail pharmacy are actually owned by non-pharmacists, and a pharmacist may not be present in a community pharmacist. Do you understand what I'm trying to say?
Of course, I come from Singapore, so I know exactly what you're saying.
Yeah, so community pharmacy may not necessarily equals to a pharmacist being present. Now, in a situation like this in Malaysia, would there be any point to actually have an intercollaboration between doctors, dentists, and pharmacists per se?
So I'm going to assume that your question is not just about oral health and the intersection between oral health and other physical health type of research, but any sort of research to involve pharmacists. Is that right? So because I'm a pharmacist myself, I'll be frank. I think the pharmacy profession has some thinking to do about their involvement in research and how they treat their own profession. So I'm sorry if I'm stepping on anyone's toes at all. I hope I'm not. In Australia, there is definitely some issue around also collaborating with pharmacists, not so much of the non-availability, it's not that. The pharmacists tend to work amongst themselves. So that sometimes can create, I feel, a bit of a barrier for interprofessional collaboration. But coming back to, and I think I've strayed slightly away from your concern, but coming back to what you talk about, a lot of pharmacies don't even have pharmacists. How do you collaborate with them? I think there are many academic pharmacists, pharmacists with research training in your school, in your university that you could engage with. And I think there are some fundamental steps that we could take with our pharmacy colleagues, academic colleagues, that we could build up the research capacity and build up the practice of pharmacy in Southeast Asia. So I say this because it's very much something that we experience a lot. I practiced pharmacy after I did my studies here in Australia. I did 1.5 years of pharmacy in Singapore, so I know exactly what it's like. Yeah, so I don't know whether I answered your question or just sound like a lot of whinging. But and another thing that you might want to think about, the way you might want to think about is sometimes we think about doctors, GPs, dentists, and the professionals when we talk about this sort of collaborative care and all that. But with that education workshop where we were not able to recruit a single dentist. In fact, it was really hard to recruit the GPs also. That we have come to a conclusion that it may not be the doctors and the dentists and all that who will be the main people to roll out that sort of more generalized awareness among the profession. It will be more like the oral health practitioners or the dental hygienists, the shop, I don't know whether it's the right word to use, but maybe the dispenser in the pharmacy, maybe the practice nurse or the reception person that will be more able to be rolling out that sort of general awareness of that need for understanding the importance of oral health care, plus also collaborative care. Does that make sense?
Yes, it does, Phyllis. Thanks. I'm just actually typing in the chat box to see if there are any dentists or medical healthcare professionals or pharmacists, but I don't think anybody is brave enough to say who they are.
No, honestly, if there is a dentist at all in amongst you, I really like to know whether I've said anything horribly wrong.
Okay, I believe some Key Eng, you want to say something?
I am actually a physician by training, but my interest is actually some minority groups. And I think some of the difficulties we've had is probably similar to yours, because when you're studying the sort of like diseases with stigma, like halitosis, retroviral diseases and things like that, we always had that difficulty of really getting good recruitment among our participants, simply because a lot of people don't like to be labeled as such. And more importantly, when they come to your specific clinic, which is meant to look at the, then it's automatically stigmatization if people notice them walking in. So I'm just curious on your side of things, how do you all deal with that? And was there any kind of like tips or tricks that enabled you to have good participation in your research? Thank you.
Yeah, no. Thank you, Key. So do you know how we started with this project at all? we didn't wake up one day and dream about it. It was actually pointed out to us by a physician in the PBRN, in the Practice-Based Research Network, to say that it's a real challenge for him to bring up that very stigmatized subject of bad breath. I mean, there are other very stigmatized topics, particularly in general practice, but that one in particular, it was mentioned, and that's how we started this project. Now, how did we deal with it? The Say Ahhh project, we very much just wanted to firstly ascertain how the different professions actually dealt with it. We know that people don't deal with it very well. In fact, what we found is that a lot of doctors avoid the topic. Even dentists avoid the topic too, even though they will be in a better position to actually point that out. Yeah, but even they would avoid the topic, and pharmacists certainly do that too. But many doctors would avoid the topic for fear of compromising that doctor-patient relationship. We find that people don't like to talk about it, and they certainly need a way to help them to bring up the topic. That's why that two fact sheets that we have produced and have disseminated quite widely, and Oral-B has helped us to disseminate that. Also, I understand in overseas countries also, the feedback so far we've got is that it has raised awareness. If you have something like this that you could that is lying around in your those fact sheets for in pharmacies or in the clinic, that raise a point of conversation between you and the patient. So we are still looking at how that is rolling out and whether that people find that helped them to start the conversation. We find that people just needed to have a point of starting that conversation. That's all. Key, if you have any good idea, I'd like to hear about it.
Okay, in the chat, we have actually Narima, who's an educator from the College of Health Sciences in our hospital. So she actually teaches student nurses the diploma program. Narima, are you okay in speaking, or you just want to actually just type in the chat box? That's up to you. Yeah, my question for you is, did you see a role for nurses in the management of halitosis? Well, while moving on, Key was saying that we should explore this more. We should do a study. No, I don't think we have done anything here in Malaysia. I'm sure, Key.
Look, I think it's a great idea. So if Key, you're interested, I'm very happy to have a chat with you. So like I said, I'm from Singapore. I suspect that the problem and that sort of stigma and not able to talk about it is not dissimilar to in your country and in Australia. So I'm just thinking about something that we recently are doing, and I don't know whether Key and the others, have you heard of the concept of normalization? So we are using the concept of normalization. I do a lot of oral health type research, even though I'm not a dentist. We're using the concept of normalization to normalize oral health and this topic around halitosis, around gum disease and all that into normal practice. So I think to reduce that sort of stigma and for physicians and doctors to be able to bring up those topics as a matter of fact is part of that normalization process. So something for us to think about if you are thinking about doing some research around that.
Phyllis, Narima is unable to chat because her microphone is not working. But I just wanted to ask, right? Why didn't you include nurses in the interprofessional collaboration in the Say Ahhh project?
So forgive me. So you heard me say that we have included diabetes educators. So in Australia, our diabetes educators, not all of them, but majority of them are nurses. So we felt that by including the diabetes educators, we are like including nurses. In hindsight, though, I totally agree with you that in hindsight, because we weren't expecting to have such a lot of trouble to recruit dentists. Like I said, recruiting GPs were not a piece of cake either. But in hindsight, we could have included the practice nurses into this as well. So our next stage, certainly our team is discussing exactly who should be the people involved in this interprofessional model. We have a model that we put together, and very much in our head, it is still the doctors, the dentists, the pharmacists and all that. But really, we are thinking that it needs to be broader when it comes to something like halitosis, which is quite, people will regard it as quite minor.
Okay. Kalyani says, I'm surprised to hear that even dentists are not comfortable to bring this issue to the patient. I personally would be very happy if my dentist informs me of my breath. Actually, I'm surprised too, Kalyani. Phyllis, do you want to comment? How come dentists?
That was what people tell us. That was what people tell us. I was quite surprised too. I think in general, it's difficult to comment, to bring that topic up with anyone. But I think a dentist would have more opportunity and more of a platform to bring it up. Yeah. But even then, they do say that it is challenging for them. So I see Waylon, is it Waylon? Say that we'll also refer to gadget. Yeah. Mm-hmm. So I mean, that's what people tell us, that they don't always feel comfortable. And if let's say they do bring it out, and the patient say, "Oh look, no, I don't think so." The opposite of pseudo-halitosis. No, I don't think so. I think it's perfectly all right. Then they might drop the subject. I think another thing to note is that even if and Waylon might want to comment on this, even if you do notice someone has really foul smelling breath and you do something, you treat it. Our participants tell us they don't follow up. So that to me is a break in the chain. If something were to be serious, that could be followed up, but they don't follow up.
Okay, great. Thank you. Do the audience have any more questions? It was a very interesting discussion. But I suppose I'm just perceived. I'm not too sure because I'm not a dentist myself. But there are a lot of primary care dentists in the Ministry of Health side, and unlike in Australia, dental care is provided very cheaply for the public to access, and they can, of course, private dental services are expensive, but the primary care dentist in the Ministry of Health side is actually fairly they're quite a number.
Quite affordable. Mm-hmm.
Yeah, very affordable. And yet I think generally the public still perceive dentists as scary people to see, and they only see them when they're really in pain. So I think having halitosis is not a good enough reason to see the dentist, I suppose, here. I think the perception is going to be the same as the patients in Australia that you actually interviewed as well.
Can I ask, since we've got a little bit of time still, and you mentioned the public dental service in Malaysia being affordable, what is the waiting list like in your public dental service?
I don't think there is a waiting list. I think you can just... There
is no waiting list? No. I'm so impressed.
I think you can just go into any dental clinic and just wait, take a number and wait for your turn. Again, it's been a long time since I've gone to the public the primary care dentist in the dental health side. I remember going there as a kid, and we never had to make an appointment. That was when I had my a tooth, a hole in the tooth, and it needed filling, and your parents dragged you down there screaming and kicking, but it was hurting you and it was driving them insane. So they had to get you treated. So there was no waiting list really.
Oh, so that is very impressive. So I might divulge some embarrassing facts about Australian public dental. So the dental, profession in Australia, most of the dentists are in private practice. Very few go into public services. I suppose I won't be wrong in assuming it's because you know the income and all that is a factor. But I think it's over 90% of people will be in private practice. So the public dental services in Australia, while affordable, as you say, it costs not a lot for people to access, but the waiting list can be anything up to 2 years. If you're not in any of the priority group. So priority group include pregnant women, older people, Aboriginal and Torres Strait Islander people, and so on and so forth. So our public service are not very accessible. And because of that, a lot of people, those people who cannot afford private service, will then go to public service, and the way the public service is structured, because by the time they can access the public service, you can wait 2 years. By that time, the condition might be so bad that you need emergency care. And in emergency care, the way the public dental is structured in Australia is dentists can only treat one issue at a time. So even though it is affordable, but because you can only treat one issue at a time, then if you have multiple issues, then the affordability then is drastically reduced. So it's interesting. I think, I don't know, sounds really quite a bit of a dream world that there is such a good public dental service in Malaysia. I wouldn't imagine it to be in Australia. That's why there's a lot of interest on my part to do work in this area, because there's a lot of policy changes that we could influence. So I see Waylon, right, we do have waiting lists, non-emergency work, and orthodontic lists might take 2 to 3 years. Oh, there you go. But orthodontic is depending on what it's not urgent. Then,
yeah, but Narima actually posted a comment down there. For the public, for the general public, you only need to pay RM1 to see a public dentist. And just a token for people to just pay something, and RM1 is like what, 30 Australian cents to actually see the dentist. Yeah.
So I don't know what you can get for 30 Australian cents at all. Waylon, can I just ask you, what about the sort of emergency appointments, or do you have priority listing for public dental patients, and how long will that take? So even here, that will take about 2-3 weeks.
Hello, can you hear me?
Yes.
Sorry, I joined the meeting a bit late, so I didn't hear your whole presentation. So if you are asking about the waiting list on the emergency condition, you mean?
Yes.
Emergency normally in public clinic, the public dental clinic, we provide emergency procedures such as extraction. And if it requires some major procedure, we still may need to schedule as a waiting list. We normally treat the emergency pain first through either do some emergency procedure like pulpectomy, like drilling a hole to drain out the pus or let out the inflammatory pulp in the tooth. So emergency procedure, it's normally done in a public clinic. And sometimes if we cannot provide the emergency procedure, we normally will advise the patient go to private, which they will be able to access that service much faster.
But more expensive though. How do you do that? So if you ask them to go to private, it's far more expensive. So,
yes. So if the patient cannot wait, let's say after the emergency procedure, we will inform them, okay, maybe we will put you in the waiting list. Then sometimes it will take maybe 3-4 months, let's say, for the restoration to replace back the temporary restoration with the restoration, or the tooth if it indicate for root canal treatment. So we will have to put in the waiting list. If the patient feels that they cannot wait for so long, then they may have to choose to go out knowing that they have to pay in a higher price.
Okay, so forgive me for saying that you sound like you guys have a lot of problems also. I think if you have groups that cannot afford it, vulnerable groups, low SES groups, and what have you, then that is a real problem. That is a real problem, and we know that people with severe oral health issues, that it affects, it is closely related to their physical health. So, and not to mention the relationship of that to mental health. So, anyone wants to do studies in collaborative care, I'm quite welcome to have a chat with me.
Okay, was there anything else from the audience? Because we have 3 more minutes left to this webinar. Okay, if none, I would like to thank Prof. Phyllis very much for her time today, for her lecture, and for sharing the experience of the Say Ahhh project with us. And to anyone in the audience, if you're keen to actually know more information or have a collaboration to look at the Halitosis project, please feel free to contact her or myself, and we'll take it from there. Once again, thank you very much for your participation, and yeah, we'll see you soon. All right, take care. Bye.